Now is my role to give you an overview on the emerging treatment strategies in the same setting. So I think it is, after hearing all this, it is safe to say that we have already moved away from the broad and very toxic immunosuppression towards targeted approaches that directly address inflammation or fibrosis or both, or we do not know. But in any chance, these therapies are more targeted, better tolerated, and this is something that is true today. But I think what stays, let's say, a bit unclear, and this is clear from the talks that you just heard, is that we are not completely sure on how to make a clinical decision in terms of the phenotype of chronic GvHD, if is it fibrotic or inflammatory, and does this, let's say, direct our treatment, and also regarding the clinical manifestations, does this is something that we can choose among different drugs. So these are the questions that are open today. But in any case, I would say that is also safe to say that we kind of have an algorithm, at least when it comes to EU, and especially after the conditional approval of belumosudil, which happened recently. It is pretty clear that, and I suppose most of us would do steroids and then Ruxo and then belumosudil. Well, that is what is approved. Of course, in the US, there is also an approval of ibrutinib in second line and axatilimab in third line. So the choice spectrum is a bit, let's say, more difficult there. But also there are drugs that we've been using more or less commonly, and these are among more commonly used options. We all have good experience with ECP, and then let's say maybe less good due to toxicity with ibrutinib, but also MMF, rituximab, mTOR inhibitors are the ones that are commonly used. So what about the new drugs? Well, I think it is clear that we have found good targets. So JAK inhibition, ROCK inhibition, TSF inhibition. These are the good targets. There are some other targets that I will mention in a second, but these are the targets that are being further evaluated with the new drugs. And I'm going to show you only the drugs that have either finished phase 2 and entered phase 3 or are still under evaluation in phase 2 trial. These are the drugs listed in the upper table. So the CSF inhibitors, vimseltinib and pimisotinib, and then the ROCK inhibitor, TDI1, and finally, of course, the most interesting, the JAK-ROCK inhibitor that was already mentioned, so rovadicitinib. Further on, I will try to tackle a bit the combinations of the approved drugs, although we know the data, and we've heard today already, is pretty scarce, but there is also an interesting way of combining ECP to the drugs that we have, as we know that ECP is not an addition of immunosuppressive treatment, because ECP works in an immunomodulatory way by increasing Tregs. So let's start with rovadicitinib, which has gone through the phase 2 multi-center study in patients with moderate or severe steroid refractory or steroid-dependent chronic GvHD in 44 patients, and that was a phase 1b/2a study. So a dose-finding study where, well, these two dosages, 15 or 10 milligrams twice a daily, were evaluated. And a dose finding was a primary endpoint, as well as safety. 2 times 10 milligrams was chosen because both dosages were well tolerated, didn't lead to any adverse events and discontinuation. Any adverse events that had to lead to discontinuation, but the most prevalent hematological adverse event was anemia. And also the overall responses were comparable, but all in all, the secondary outcome of best overall response was around 86%, a little bit more in the steroid-dependent cohort. And then other secondary endpoints were 12-month failure-free survival of 85%, and also lots of patients could reduce corticosteroid dose, and 60% of patients had improved GvHD symptoms. And this led to the phase 3 trial with a dosage of 2 times 10 milligrams a day. So the next one is a second generation ROCK inhibitor where we also have the results from a phase 2 study, which was evaluated, so similar to like belumosudil in patients with moderate severe chronic GvHD after 1 to 5 prior lines of therapy in 60 patients. And here, again, two dosages were evaluated, 200 milligrams and 400 milligrams, with a primary endpoint of overall response, as you can see, being better in the 400 milligram cohort of 86%. And then it was really interesting how those hard to treat groups had also very good responses. So over 80% in severe GvHD in more than 4 organs, in more than 3 prior lines, in prior ruxolitinib as well. And when it comes to safety, treatment emerging adverse events and treatment related were reported in 51 and 38% of patients, with elevated bilirubin being the most common one. Failure-free survival at 9 months was better in the 400 milligram group, so 77 to 53%, and overall survival at 12 months was also better, 92 in comparison to 86 in the 200 milligram cohort. And this data actually supported 400 milligrams daily as the recommended dose for the planned phase 3 trial. Last two agents are the CSF inhibitors. Well, actually, one is oral switch control TKI designed to inhibit CSF. And this is actually a drug that has been evaluated in tenosynovial giant cell tumors and went to phase 2 and 3 there and had approval from FDA and EMA recently. While in chronic GvHD is currently being investigated in a phase 2 trial. So again, a dose-finding study with primary outcomes to be evaluated frequency and severity of dose-limiting toxicity, adverse and severe adverse events, and including patients who had at least 2 prior systemic lines of therapy and no prior CSF inhibitor use. And finally, pimisotinib. Also what we have are, already a bit older phase 2 data on first 28 patients. This is from the end of 2024, so no follow-up after that. So this study was actually similar. So again, a dose-finding study with overall response as a co-primary endpoint and safety, which defined 10 milligrams as a dosage that would be used further on, with response in 60% of patients, time to response of 4 weeks, and was also proven to be well tolerated and safe, with only 20% of patients having severe adverse events, and mostly these being increased liver enzymes. The other point is the agents that we already have. We already know that the data on combining these agents are really scarce, but I'm still going to show you what we have. Of course, always the problem is, are we going to have better efficacy and the same or less or more toxicity, which is actually expected? There is some data, a recent one on, of course, these are all single-center studies. This is retrospective on axatilimab combination with both ruxolitinib and belumosudil, or one of those two agents, where only 8 patients were evaluated and published recently, where you can see that there was a 25% of response per NIH consensus criteria and 75 per clinically significant responses. And among those responses, 4 patients had all 3 drugs. One of them had AXA and ruxolitinib, and the other one had AXA and belumosudil. And what was actually surprising when combining all these drugs, there were 3 grade 3 severe adverse events, but all occurred in the same patient. When it comes to belumosudil and ruxa, this is maybe the hugest one. So retrospective study again, belumosudil with ruxa in comparison to belumosudil with standard agents, and those standard agents are prednisone, tacrolimus, and sirolimus, where you can see here on the left, and in all organs, belumosudil and ruxolitinib were more efficient, or even in liver, there was no efficacy when belumosudil was combined only with a standard agent. And this led to also a better overall survival with the belo and ruxo combination of 92% without excess toxicity. Infections were similar in both groups of patients, while non-relapse mortality seemed to be lower, 8% in comparison to 20% in the belumosudil and standard agent combination. Finally, the ECP combination, I think that these are the ones that are really interesting to us, because we are almost sure that this is not going to add additional toxicity. So this is already all data from Robert Deiser's group, where ECP was added to ruxolitinib in 23 patients, and partial remissions were seen in 65% and complete in 9%, so a good response of over 70%. With the best responses in musculoskeletal, skin, and GI tract, median time to response of 5 weeks, and let's say normal or expected rates of cytopenias and infections in terms of CMV reactivation. Only a small set of data on ECP and belumosudil where some information showed that partial remissions happen in 2/3 of patients, while patients who are followed for a long time actually have a continuous improvement, so improvement that continues to be present and grow in 75% of patients without reported severe adverse events. And last but not the least, the ECP and low-dose EL2, because it was hypothesized that low-dose EL2, which is relevant for recovery of Tregs, can improve what ECP does. And actually, this was evaluated in a way that patients received 8 weeks of ECP, followed by 8 weeks of ECP and EL2. And that was well tolerated, and the group with ECP in addition of EL2 had twice as good responses with twice as more partial remissions and less progressive disease. No, not much more serious side effects. And what was also interesting, they saw that actually ECP patients had lower CD4 and CD8, while the addition of EL2 was responsible for the real induction of T regulatory responses, which was not completely expected. So all in all, I think I can conclude with what I said at the beginning. We have good targets. The drugs that are being evaluated are, let's say, aiming at the same targets. Let's see if they can do better with even more targeted approach. But with now having the good drugs, I think it is important that we learn how to combine them and make the most of their efficacy without increasing the toxicity.